Ladies and gentlemen, it's about to turn over to 3:30, so I think we'll make a start. So ladies and gentlemen, friends, colleagues, distinguished guests, good afternoon and welcome. My name is Stephen Palmer. I'm the Industry and Innovation Lead for the Randwick Health and Innovation Precinct, and it's my honour to be your MC for today's event. The Randwick Health and Innovation Precinct partners acknowledge the Bidjigal people, who are the traditional owners of the lands, seas and waters. We pay our respects to elders, both past and present. Our seminar series, Mind the Gap, started as an online forum 2 years ago to encourage discussion and to disseminate information about innovation, primarily amongst our precinct community. We quickly realised that a more important purpose could be served by opening it up to all, and it's very gratifying to see it evolve into this in-person event today with such a large and diverse audience. Today's seminar is entitled The Future of Healthcare, and we are delighted to have an impressive assembly of experts and key opinion leaders drawn from different backgrounds to explore this topic and to discuss how the Randwick Health and Innovation Precinct might support that future development. A very warm welcome to you all. There's no doubt that future healthcare faces significant challenges. The New South Wales Health Report, Future Health Report, places rising demand and changing demographics as two major threats that need to be addressed. It's predicted that demographic changes and changes in the disease burden, especially in areas such as mental health, diabetes, chronic disease, and communicable diseases such as COVID-19, will place significant additional burden on our health system by 2032 that may involve up to 1.7 times more activity than was experienced in 2019. At the same time, clinical service delivery continues to be transformed through medical research, new models of care, and health technology innovation. New technologies are increasing the power and capacity of healthcare through precision medicine, better diagnostics, more accurate prediction, and better usage of health data to guide best practice. Such work is energised and enabled through collaboration between organisations, and the support of health precincts, such as the Randwick Health and Innovation Precinct, is a critical enabler of such collaboration. That's just a taster of some of the topics that I think will emerge today, and I'm very much looking forward to hearing from those who are much better placed to talk about them than I am. We'll begin with the opening addresses. First, we'll hear from the Chair of the Randwick Health and Innovation Precinct Council, followed by the Chief Executives of the Precinct Partners or equivalents. And then we'll have our keynote address from Professor Michael Kidd, the former Deputy Chief Medical Officer of Australia, and now the inaugural Director of the Centre for Future Health Systems at UNSW. Amongst other things, he'll be telling us about the function of that centre and some key lessons learned from the COVID-19 pandemic. Following that, we have a panel session with experts drawn from government, industry, academia, and the health services to unpack some difficult questions regarding future healthcare and how we might work together to solve them. But first, let's begin with the opening addresses from our precinct partners. Firstly, I'd like to invite to the stage Dr. Michael Still in his capacity as the Chair of the Randwick Health and Innovation Precinct Council. Michael has had a 30-year career in health investment, banking, infrastructure and property finance, and global experience as CEO of listed and unlisted companies. He's the former Chair of South Eastern Sydney Local Health District and was recently announced as the new Chancellor of Wollongong University. Michael.
Thank you very much, Stephen. And good afternoon to you all. It's lovely to see you here and thank you for joining us. And I too would like to acknowledge our special guests and particularly our partners. As Stephen said, I'm Chair of the Randwick Health and Innovation Precinct, which is my great delight. And you'll hear it referred to variously as RHIP or RIP during our afternoon. This event is entitled The Future of Healthcare. It's a subject that concerns all of us, certainly from a personal point of view, of course, but also many of us here today as professionals. Stephen referred to the Future Health Report, which was published in 2022 by the New South Wales Ministry of Health. It notes that New South Wales public health system is the largest in the country, is high performing, delivers safe, quality care to its citizenry, but it also notes that our system's ability to perform well into the future will be challenged if the system does not adapt to the emerging environment. In this emerging operating environment, pressures will include patient needs, which are changing constantly, the growth in the number of patients, and the volume and the complexity of the care they require, as well as, of course, the demand and the expense of new technologies, which nevertheless create opportunities for improved patient and community care. By 2061, it is projected there will be 11.5 million people living in New South Wales. That's 3.3 million more than there were in 2020. That's a very significant increase and will place an enormous burden on healthcare facilities, infrastructure, and professionals. Life expectancy at birth is projected to reach 91.7 years for women and 89.4 years for men by the same year. While most of the population growth will occur in the metropolitan centres, 1/3 of our population lives in regional districts, and those districts will suffer, if that's the right word, a faster increase in ageing as a population. To solve these challenges, we need healthcare providers, academic medical research centres, health technology industries, and all levels of government to work effectively together to develop and implement the required solutions. I believe that this precinct and health and innovation precincts more generally will serve as agencies of collaborative development and sustainable change for our health systems. Randwick is an organised community comprising major teaching hospitals for adults, children, women's health. It's co-located with 5 independent medical research institutes and a university that is ranked among the top 50 in the world. Together, our precinct partnership provides a rich ecosystem of clinicians, patients, researchers, professional staff, students, infrastructure, and of course services that has its central focus here in Randwick, yes, but is also embedded in the local, national, and international health science networks through the many affiliations that the precinct maintains. And here I want to sincerely thank each and every contributor to our extensive collaborative efforts. Through its extensive partnership network, the precinct leverages its scale, diversity, and expertise to positively influence and impact health and its outcomes, striving to become a transformative and collaborative place of excellence which enhances and nurtures lifelong health. As a precinct, we also acknowledge that our future success is predicated on robust relationships with industry. Of course, University of New South Wales is already home to several health technology companies. A new collaborative infrastructure developed, and as new collaborative infrastructure develops, we look forward to a future where many more such enterprises, large and small, can call Randwick their home. So as you listen and participate in this afternoon session, I urge you to think about how we might all take full advantage of all that our partnerships can offer and work together to improve the future of healthcare. We might also think about how we can influence government entities, including Jean-Fred Levesque, who's with us here today, to understand just how much proper funding for precincts is needed and what it will achieve. He doesn't need telling, he needs our support. So I trust that you enjoy the discussion as we will enjoy your contribution. Thank you.
Thank you, Michael. I'd now like to invite to the stage Catherine Cox, Chief Executive of the Sydney Children's Hospitals Network. Beginning her career as a physiotherapist, Catherine's accumulated many years' experience in policy and planning within the New South Wales Ministry of Health, including being the interim Chief Executive for Health Infrastructure. Catherine.
Thank you, Stephen, and hello everyone and welcome. I'd like to start today by acknowledging the traditional custodians of the lands on which we meet and pay my respects to elders past, present and emerging, and extend that courtesy to any Aboriginal colleagues joining us today. So the Sydney Children's Hospitals Network is the largest paediatric healthcare service in Australia. It incorporates Sydney Children's Hospitals Randwick, Children's Hospital Westmead, Bear Cottage, Nets, the Children's Court Clinic and Kids Research. So each year we provide care for nearly 160,000 children with nearly 60,000 ED attendances, more than 105 hospital admissions, I've got that round the wrong way, 105 ED presentations, nearly 60,000 hospital admissions, and over 1.1 million non-admitted occasions of service. So we care for children all over New South Wales, Australia and internationally. We lead paediatric translational research through Kids Research with over 250 open clinical trials, and we received over $32 million in grant funding in 2023. And we do this in partnership with our university and MRI colleagues. Over $658 million is actually being invested in Sydney Children's Hospital. It includes the Minderoo Children's Comprehensive Cancer Centre, which brings together the Children's Cancer Institute and the Kids Cancer Centre to be a powerhouse in cancer care and research and a first for Australia. So with that quick snapshot of who we are, I'm very mindful that the network has great responsibility for the children and young people that we care for, who will not only be the beneficiaries of these services, but also the future leaders in the very areas that we're talking about today. So, on to the big transformations for healthcare. There'll be no surprises for any of you that the first innovation is the connection of the vast volumes of data that we hold to be able to move to predictive and prescriptive analytics, and that will really shape the delivery of healthcare. Advancing technology means we have access to more genetic information than ever before. This is leading to an increase in research and development using genetic technology to develop therapies. This has a critical impact on paediatric healthcare, as early intervention for many genetic diseases can significantly improve outcomes, not just in childhood, but in adulthood. The progress in medical devices and virtual technologies, along with these advances, will have a major impact on childhood medicine. So we're very focused on building the capacity and the capability of our current and emerging researchers to pave the way for the future of paediatric medicine and healthcare, not just in New South Wales, but across the country and around the globe. So the full potential of our current digital systems has not been fully realised. Patient and health services data is locked away in fragmented systems that don't talk to each other, and as many of you here today will know all too well, extracting it is difficult and time-consuming. So we're aiming to make progress on that through projects such as the Learning Health Initiative, which will see the implementation of a learning health system and big data for little people, which seeks to improve care and outcomes through using data insights from what previously wasted physiological data that we collect in critical care environments. So the other issue that I wanted to touch on is sustainability, and that encompasses all areas of healthcare provision. At the network, we're committed to an environmentally, socially and financially sustainable future for our children and their coming generations. We know that it really matters to our children and young people that we live on and leave them a really healthy planet. Healthcare contributes to greenhouse gas emissions through energy consumption, transport, and the manufacture of products, their use and their disposal. Globally, healthcare delivery is responsible for generating 4.4% of global net emissions. Our healthcare system alone generates approximately 7% of Australia's carbon footprint. An estimated 40% of Australia's healthcare carbon emissions are caused by harmful or low-value care. So climate change is posing significant challenges to all of us in the sustainability of healthcare, with increasing risk to our assets, our infrastructure and our hospital resources. It's not only threatening the physical and mental health of our communities, but it compounds health inequalities among vulnerable populations. The network has set a net zero target of 2035 for those emissions that we can control and 2050 for those outside our control. So climate risks present us significant opportunities to change our operational areas and our built infrastructure. 1 billion children globally are at extremely high risk of impacts of the climate crisis. Children are more susceptible to heat stress and dehydration and more sensitive to exposure to air pollution and smoke from bushfires. They are at increased risk of infections and particularly vulnerable to detrimental effects of climate change on mental health. The rise in extreme heat is driving up demand in our emergency departments, and research conducted by the network clinicians has shown a rise in mental health issues among young people, including an increase in suicidal tendencies as a result of rising temperatures. We need to be prepared, resilient and agile in the face of these challenges. So we have the opportunity through our RHIP partnership to create networks that reach across the lifespan and clinical areas, work with our university and MRI partners to support breakthroughs that make real impacts on patient outcomes and actually help us better prepare for the future. Thank you.
Thank you, Catherine. Next, I'd like to invite Toby Wilson to the stage, Chief Executive of the South Eastern Sydney Local Health District. Toby also began his career as a physiotherapist, and he spent many years in senior management roles in health, including the Chief Operating Officer of Royal Melbourne Hospital and the General Manager of the Prince of Wales Hospital. Toby.
Thanks, Stephen. Another, well, I won't say another, but I certainly claim to be a washed-up physio. Very proud of that, and really excited that UNSW has now introduced their physio course and hopefully growing more physios and more leaders across the health system. Can I also start by acknowledging the traditional custodians of the land, the Bidjigal people of the Eora Nation on lands on which we gather today. South East Sydney is a really proud member of RHIP. It's been something that's been really important through my career, the importance of that affiliation with research partners, with academic partners, when you're delivering clinical care, because we know that if our clinicians are active and they're researching, then the care that they provide to the patients will be of a higher quality, and the outcomes that our patients therefore experience is of a higher quality. So it's a bit of a no-brainer for us to want to be heavily involved in RHIP, and we are very grateful for that. I think the other thing that, and I'll touch on a little bit with one of our challenges as well, is we also acknowledge that when we're trying to talk about attracting the best people to work within our healthcare system, the best clinicians don't just want to be clinicians. They generally want to be research active. They generally want to be involved in education. They generally want to be cutting across all those spectrums. And so none of us, and as an individual organisation, can attract the people that we want to be attracting to our organisations independently. And that's where the partnership with through RHIP is so important for us. The ability to attract clinicians that want to continue to work clinically, but also want to be involved in research, in education, that might be able to get an affiliation with the university or with one of our MRIs. The relationship that we have with the Children's Network as well offers us a unique proposition that doesn't exist everywhere, and that is a real differentiator when we're trying to recruit the best possible clinicians. I think some of the other things that I just want to call out, that the value that comes for us from RHIP, there's a lot of value add opportunities that come through this partnership that we wouldn't see otherwise. Catherine and I spent a good 15 minutes just debriefing on some of the challenges that it comes when you around running health services, and you don't get to often do all the good stuff that you would like to be doing. the precinct offers an avenue for some of that good stuff to occur, and particularly for some of those opportunities to be shared with our teams, with our frontline staff, and things like the 24-hour tea room, things like the ability to get involved in some of the research activities, some of the innovative forums, some of these type of things that just would not exist if we were asked to do it all by ourselves. So those partnerships are so important for us, and I guess that's what we see as what RHIP starts to deliver for us. We were asked to comment on a couple of innovations and particularly relate them back to RHIP, and I'm probably going to fail dismally around that, but I'm going to throw out the challenges that are kind of keeping me awake and maybe what some of those solutions start to look like. And the first is workforce. And I think one of the things that has been a topic ever since I started many years ago as a physio was the projections of what the workforce is going to look like, and eventually when we're going to run out of nurses. And you always see these graphs of you need this many nurses and this is how many nurses are being trained, and they at some point, sometime around now, the world was going to end and we were going to run out of nurses, and the same can be said for allied health and for doctors and all of our specialist craft groups. And those graphs were pretty right. Like, to be honest, we've got some pretty serious challenges around workforce at the moment. Some of that also has been added to with the last couple of years of the pandemic and the experience that our workforce has been through, particularly our frontline staff, as well as some of the generational changes. And I think we often underestimate, and I think this has been one of the things that's really been apparent to me and to a number of people through the system is we survived for many years in healthcare on the goodwill of our workforce. We as a clinician, as a physio, you would go above and beyond. The patient needed to be seen. You stay back an extra couple of hours. You would see the patient. Our workforce has shifted. Our workforce is tired from the pandemic, and they've also started to reset that value proposition. Where do they want to spend their time? Am I going to spend an extra couple of hours with the patient, or am I going to spend the extra couple of hours with my family that I don't get to spend enough time with anyway? And I think that is something really significant for us to address over the next 10 to 20 years, because those old workforce models where we used to rely on doctors happily working 60 hours a week and that was just part of your training program and that's all okay, that's not okay. We're seeing it coming through in our nurses now. A number of new grads will do 0.8 rather than full time. We're seeing it come in our junior doctors. They're not prioritising overtime as much as they used to. They are prioritising the fact that they want to get home and they want to have a life. So we need to rethink our workforce models. And some of this is going to come from innovation. Health is probably in many ways a slow adopter around a number of innovative models that we could look at which will address our workforce challenges. We have incredibly clunky systems. Recent study out of the NHS showed that more than 40% of junior doctor time is spent on administrative tasks that are low value or no additive value to the outcome of the patients. That's a huge amount of wasted time that we have that we need to go back and start to rethink how we deliver these services and deliver what services we actually ask for from our workforce, because we're not going to be able to sustain that and we're not going to be able to attract that long term. So automation, the use of AI, all of these new technologies coming through, that is again the opportunity for us with our partners through RHIP to look at different ways that we can start to introduce these models in ways that supplement and support our workforce, not instead of our workforce, but actually let our workforce focus on what is actually going to add value for them. The other one that I think is a big disruptor that we're seeing, and again, health being slightly insulated from this, but only for a matter of time, is around consumer expectations and the way our consumers want to engage with healthcare. And we've seen this in pretty much every other sector, and we are seeing it starting to come in healthcare. Probably not as much as we've seen in banking and other retail areas, but we know that our consumers want to interact with us in a different way. We are slightly protected because of some of the legislation and things that sit around that, but that's only going to hold up for so long before we do see disruption coming in this space. And again, this is an area that we are really proud of some of those relationships that we have in RHIP. One of the innovations that exists within the newly opened acute services building at Prince of Wales is our virtual health hub, which starts to talk about how we can streamline the care delivery of virtual care in people's homes and look at taking that to scale. And we have really big big aspirations around 10,000 people in the community being able to access their care virtually and interact with us in a proactive manner rather than turning up to the emergency department when something goes wrong. And we're really grateful that the work that our clinical teams have done in partnership with UNSW and others through the development over many, many years, and we're definitely building off those coattails with what we're looking at delivering in that space going forward. But again, there's so much more scope in this space. We know that there's some really interesting models that are developing around the world with the use of asynchronous communication, the use of chatbots that are really changing the way that our patients can interact with their clinical teams, not necessarily our building our models around when our clinical teams are ready to see people. And that's going to take a shift in the way that we think about how we deliver care. But again, this is going to be forced on us. This is the challenge that's coming over the next 20 years. Our consumers, our patients are not going to want to access, they're not going to be happy turning up to the emergency department and sitting there 8 hours waiting to see a patient for something that they knew could have been managed in a different way if we'd intervened at a different time. But again, really grateful for the partnership that we've got, because I believe with the moving parts that we've got within Randwick, we have the opportunity to start solving those problems, and we're really keen to be at the front line trialling those solutions. So thank you.
Thank you, Toby. I now invite Professor Attila Bronx to the stage. Beginning his education in chemistry here at UNSW and at the University of Oxford, Attila is now the Vice-Chancellor and President of UNSW and the former Vice-Chancellor and President of UTS, and spent 7 years at CSIRO, many of which as the General Manager of Science, Investment and Strategy. Attila.
Thank you kindly, Stephen. A very warm welcome to you all. And again, I'd also like to acknowledge the traditional custodians of the land, not just as the custodians of the land, but as the traditional custodians of knowledge of this place. Knowledge is the heart of what we are as a university, but knowledge is the heart of our partnership, using knowledge to tackle the challenges we see around us. UNSW is very proud to be part and a founding partner of the Randwick Health and Innovation Precinct. To meet the healthcare needs of the future, as we'll hear about today, we need to really reimagine health. Now, already you've heard from Michael some of the challenges we face and the demographics that are going against us. From Toby, also about the workforce challenges that are facing us. But also from Catherine and Toby, the innovation that we've already got and we hope to aspire to do that will tackle these challenges head on. This precinct is a vital part of it. It provides the opportunity to really reimagine health and to innovate by bringing together world-class education, research, healthcare organisations, and importantly, fostering this greater collaboration between all of us, between clinicians, researchers, students and educators and industry. To integrate patient care, research and education, this is what is going to enable the new innovation approaches to diagnostics, to monitoring, to prevention and the treatment of disease. UNSW, as you can probably tell, is delighted with the partnership, and we are very proud to bring our deep expertise in research and education. But we bring it not just from our health and medicine faculty, but from all our faculties. As a fully integrated hospital university campus, the precinct links UNSW's activities in health from right across the university with existing and emerging healthcare services. No longer here at UNSW do we think health is only a matter for the Faculty of Health and Medicine, but is one that all of our disciplines, all of our faculties, the whole university will play a vital role in. Now, we've seen the precinct transform over the last couple of years. The opening of the new Prince of Wales Acute Services Building last year was an exciting milestone. UNSW's Integrative and Acute Services Building, which will open later this year, directly connects to this facility. 10 stories of dedicated education and research spaces will be situated right alongside the Acute Services Building, bringing, again, together people such as researchers and clinicians and health experts. The soon-to-be-opened UNSW integrated spaces will house more clinical prototyping, testing laboratories, research zones, and more. And this is just the start. It's important this precinct is far more than the buildings we're building now. The heart of any precinct is people. Now, as the others, a couple of innovations that I think will shape the next few years. And I'll start with sort of two innovations and a thought and innovation in general at the end. The first, I think, is RNA science. This is a field that UNSW is wholeheartedly committed to, with the recent $25 million investment in the UNSW RNA Institute. We've all seen the importance of RNA science with the development of mRNA vaccines during COVID-19, but as we all know in this room, RNA science and technology is far more significant than this. It has the potential to treat cancer, genetic diseases, and much, much more. We're only at the start of this. The RNA Institute brings together researchers from UNSW Science, from engineering, as well as medicine and health, with collaborative input from a whole host of other universities and institutions. The aim of this is to accelerate the development of RNA technologies for the advancement of health on a whole lot of fronts. Secondly, and similar to Catherine, I think one of the biggest things we need is around big data and technology. A transformative role in healthcare will be how we use our digital technology going forward. Take, for example, UNSW's Centre for Big Data Research in Health. It tackles any health issue that can be informed by large-scale electronic data. Its expertise spans fertility, early life, chronic diseases, mental health, musculoskeletal conditions, improving surgery and devices, conditions that come with ageing, and again, the possibilities for this research is endless. One of our proud examples is the Tyree Foundation Institute of Health Engineering. It supports the development of transformative medical technologies by bringing together, again, clinicians and technologists with industry to identify unmet healthcare needs and to use data to solve these. It develops research programs and education across the pillars that connect health, bionics, biorobots, image analytics, and translational biomechanics. Now, none of this research would be possible, none of the innovation would be possible without collaboration. Collaboration between individuals, collaboration between organisations. I've sometimes described innovation as a contact sport. It's about people connecting with each other, bouncing off each other. It's only through collaboration that these innovations can be truly realised. And actually, one of our simple roles as an organisation is merely to support and encourage the collaboration of fantastic people. And with fantastic people together, we will shape the future of our health system that will deliver and meet the challenges that Michael outlined earlier. Thank you.
Last but not least, I'd like to invite Professor Michelle Haber to the stage. Michelle's the Executive Director of the Children's Cancer Institute, one of our premier medical research institutes within the Randwick Health and Innovation Precinct. Michelle has dedicated her professional life to improving clinical outcomes for children with cancer and is world-renowned for her work in neuroblastoma and leukemia, and is now driving major initiatives in molecular oncology that I'm sure she'll tell us something about now. Thanks, Michelle.
Good afternoon, everyone, and I'll add my acknowledgement to the traditional owners of the land, the Gadigal and Bidjigal people on whose unceded lands we meet today. So Children's Cancer Institute, with nearly 350 staff and students, is a proud partner in the Randwick Health and Innovation Precinct. And like all of the affiliated medical research institutes in the precinct, we benefit enormously from being in close proximity to world-class clinical facilities which facilitate the translation of our discoveries into the clinic, and to world-class educational facilities through UNSW Sydney to facilitate the training of the next generation of researchers in our respective fields. At Children's Cancer Institute, just as an example of how the precinct works together, our vision is to save the lives of all children with cancer and to improve their long-term health through research. And our motto, very simply, is it's not if, it's when. And with cancer killing more children in Australia than any other disease, our work is quite critical. Our researchers work so closely with clinicians at the Kids Cancer Centre at Sydney Children's Hospital Randwick, also a proud precinct partner, as you've heard from Catherine. And in fact, we share a 40-year history of close bench-to-bedside collaboration. And it's that close collaboration, that partnership that Attila spoke about, that has led to Australia's National Precision Medicine Program for Children with Cancer, the Zero Childhood Cancer Program, or ZERO, in which our two organisations jointly lead and which includes every children's hospital in the country. In terms of innovation, in 2017, ZERO was rolled out nationally to include all children with high-risk cancer. And last year, it expanded to become available to every Australian aged 0 to 18 years diagnosed with cancer, irrespective of their cancer type or where in the country they live. Now, this is the first time that precision medicine has been available to every child diagnosed with cancer not just in Australia, but on a national scale anywhere in the world. So we really are blazing a trail. And I see Zero as a perfect example of an innovation that will transform the way in which healthcare is delivered in the future. And let me explain why. Zero is an entirely new approach to treating children's cancers. It doesn't involve treating all children with the same type of cancer in the same way, which has been the historic paradigm, but rather it recognises that every child's cancer is unique, and therefore treatment should be tailored to the precise genetics and biology of each individual's disease. So by comprehensively analysing each child's cancer at a molecular genetic level, we can look for genetic alterations responsible for driving the cancer's growth, and then identify a drug or drugs capable of targeting those alterations on an individual child-by-child basis. But more than that, molecular analysis provides a whole new way of understanding a child's cancer. From a clinical perspective, the results may potentially inform diagnosis, prognosis, risk classification, and treatment. But from a research perspective, these data provide unprecedented insights which will ultimately benefit many tens and thousands of children, more than those just enrolled at any one time on the Zero program. And this is having real clinical impact. Our recent results from the first 400 children enrolled on Zero clearly show that precision medicine is significantly more effective than current standards of care treatment in terms of improved 2-year survival rates. So our aim all along in building Zero has been to lay the foundations for a new model of care within the Australian health system, one in which precision medicine is standard in the treatment of cancer. And if you take this concept and expand it more broadly, it's clear that precision medicine could, and I believe will, revolutionise the way in which many illnesses are treated. And if you ask, is this the way of the future? I truly believe that it is. A second innovation that we are working on, which I believe will also revolutionise the way that cancer is treated, is a powerful new clinical tool called liquid biopsy. And this is a new way of sampling a child's cancer, based on a simple blood test, not invasive surgery, but again harnessing this deeply comprehensive genetics of each child's cancer. And we've shown, and we will be implementing, the fact that this can be used to monitor cancer more effectively than any currently available scan, and importantly, without the need for a child to come into the hospital to have that test. Think of the implications of that for rural families or families living far away from the treating centres. Liquid biopsy will allow us to see in real time how a tumour is responding to treatment, if the treatment needs to be changed to avoid relapse, and if so, when it should be changed and what it should be changed to. And so in the context of Zero, this will facilitate ongoing personalised treatment recommendations throughout the entire patient journey. I mentioned earlier that our institute and the Kids Cancer Centre have worked together for many years. And by the end of next year, that collaboration will reach a whole new level when both organisations move into the Minderoo Children's Comprehensive Cancer Centre, which is currently being built, as Catherine mentioned, the first of its kind in Australia. This surely is an exemplar of the ideal future state in which clinicians and scientists are working with a single common strategy in a totally integrated environment to improve health outcomes. To me, this is innovation, this is the future, and I think, as we'll hear this afternoon, this is a hugely challenging time, but also an enormously exciting time to be working in health.
Thank you very much, Michelle. Well, that concludes the introductory addresses by our senior delegates from the Precinct Partnership. And I'd now like to move to the keynote address from Professor Michael Kidd. Michael Kidd's the inaugural director of the Centre for Future Health Systems here at UNSW and holds a joint academic appointment as Professor of Global Primary Care and Future Health Systems at the University of Oxford. He served as the Deputy Chief Medical Officer of Australia throughout the first 3 years of the COVID-19 pandemic and many of you will probably remember his face from the broadcasts about recommended public behaviours during that era, and there's no doubt that his guidance helped our communities stay safe during that period. Thank you, Michael.
So good afternoon, everybody, and thank you for the opportunity of being here with you today. I also acknowledge the traditional owners of this beautiful country that we are privileged to work on here in this wonderful part of Australia. I also want to extend to all of you a happy Valentine's Day. And if any of you feel that you need to sneak out during my talk to get home to someone special a little bit early, I will totally understand. So let's talk about the future of healthcare systems and where would we like our healthcare systems to be in the future. Now, if I ask you, what would you like to see in healthcare systems 10 years from now? The answer you give me will probably be different depending on whether you are responding as an individual or responding as someone working in the health systems. As individuals, each of us would like for ourselves and our loved ones to be able to access the healthcare services we need when we feel we need them. For those who are developing health systems, it's a lot more complex in working out what we need. And this is where we get some of the tensions for our governments and for our policymakers in deciding where to invest in response to different demands. But if I was asked to ask you as someone working in the health system, what would you like to see with your health systems 10 years from now? Would it be that we have increased equity in our healthcare systems? We live in the country of the fair go. Would we like to see everybody having equal access to wonderful healthcare services and probably more importantly, equal outcomes from encounters with those healthcare services? Would we like to see life expectancy continue to rise in Australia? We've seen it go backwards during COVID-19 in some high-income countries in other parts of the world? Or would we like to see increased quality of life for everybody in our country? Would we like to see greater investment in preventive care and health promotion so people don't need to access our healthcare services perhaps at as early an age as they do now? Would we like to see better care for people with chronic disease or with mental health concerns? Would we like to see a reduced burden on our emergency departments and our hospital wards? Would we like to see greater investment in strengthening primary care and community-based healthcare services? Would we like to see new technology being appropriately used in our healthcare services, digital health, and many of the innovations that we've heard about already today? Would we like to see more team-based models of care and more person-centeredness in the care that we provide to the people who come and encounter us in our health services? Would we like to see a healthcare workforce which is happy to come to work, happy to do and fulfilled in the work that they do? And would we like to see a healthcare system that is well prepared for when the next emergency comes and hits, as of course we saw with COVID-19? To address some of these challenges here at the University of New South Wales in our partnership with Oxford University, we've set up the UNSW Centre for Future Health Systems. And this centre, as the Vice-Chancellor has alluded to, is bringing together researchers from all of the faculties of this university, acknowledging that many of the solutions to future health system challenges don't just rest with doctors and nurses and public health people. They rest with architects and computer scientists and social scientists and people involved in law and ethics and people involved in business and economics and people involved in urban design, many different people coming together in this centre. And I'd like to acknowledge and thank the deans of each of the faculties of this university who are supporting the appointment of postdoctoral researchers to be based in our new centre. We've settled on 7 initial themes for our centre. They're up here on the screen. The first theme is around equity. Healthcare equity, universal access to healthcare is the #1 global health challenge. It's the one Sustainable Development Goal of the United Nations, which is focused on health universal health coverage, how to ensure that everybody in every country in the world gets access to quality healthcare services. The second area is around what do we do with our hospitals. How do we transform our hospitals? We've already heard from some of the senior leaders in our hospitals in the precinct, so that we make use of new technology and new knowledge as it becomes available and rapidly incorporate that into the care that we provide. But at the same time, how do we make our hospital services more person-centred? And how do we bring down the walls of our hospitals to get better integration of care for people, recognising that people may be in a hospital for a short time, but then of course they go back home and the care that they receive needs to continue. What do we do about strengthening our primary care system? We hear a lot in the media about the challenges for our system of general practice in Australia. What do we do to strengthen that system and to encourage more team-based care, to encourage better integration of care with those providing aged care services, disability care services and other social care services? How do we do more to support chronic disease management and the management of mental health conditions through our primary care services? Are there services which we could deliver more cost efficiently and perhaps at an even better quality that we currently deliver through hospitals that we might deliver through a strong primary care system? And what about new technology? How do we look at bringing new technology into our healthcare systems, particularly in a way where we focus on the safety and quality elements of new technology, not just technology for technology's sake, but technology where it's shown to improve the quality of care that we can provide. And of course, we've seen a great example of that with telehealth over the last 3 years. The biggest change we've seen to our universal health insurance scheme in Australia, Medicare, since it was first established 40 years ago, was the adoption of universal whole-of-population telehealth during the COVID-19 pandemic, a reform which continues today. Our workforce, we've heard already about workforce from Toby and others. How do we make sure that we are training the right people in the right places with the right skills to meet future population needs, rather than continuing with models of training and preparing a healthcare workforce that may have been suitable in the last millennium, but may not be suitable for the years ahead. We've already heard about climate change, and in our centre what we want to look at is not only how we can mitigate the impact of our health systems on climate change, but also how can we help our health systems to prepare for the ongoing challenges which climate change is going to bring to our society as things worsen over years ahead. And finally, we've lived through a very dramatic period with the COVID-19 pandemic. It's very important that we learn the lessons from the pandemic and we adopt them and implement them into reforms of our healthcare system. And that's where I want to focus on for the last few minutes in this keynote. So firstly, COVID-19. Firstly, I want to thank everyone in the room who was involved in supporting the community during the COVID-19 pandemic. I know there were many people in this precinct in many different roles who went above and beyond what was normally expected of them during the COVID-19 pandemic. So to those of you in the room, thank you for the contributions which you made to our society. What I worry about is that we're rapidly forgetting that that's what people did, that people stepped up and went beyond the call in looking after the society, our population, during COVID-19. And we're also forgetting many of the lessons which were learned. Lessons about how we deliver healthcare, lessons about the design of our healthcare facilities and our hospitals, issues like ventilation and appropriate airflow. But perhaps most importantly, lessons about the social inequities that COVID-19 shone a spotlight on, especially in our big city here of Sydney, but also in other parts of New South Wales and in Australia. One of the areas that my research team has been looking at is what was the impact of COVID-19 on primary care services, not just in Australia, but in countries all around the world. We wanted to look at what were the additional burdens which were experienced, but also what were the contributions which were made by primary care services during COVID-19. We found that there were a large number of challenges which were faced by our healthcare systems, our primary care colleagues, during COVID-19. One of the most obvious was the shortages of personal protective equipment during the early phases of COVID-19. Who knew that most surgical masks were made in the Wuhan province in China? And of course we had shortages which were very serious in many parts of the world. People going to work not knowing if they were going to have the protection that they needed, and at risk of contracting COVID-19 and bringing it home to their own families. But also many other challenges in the way that our health systems were designed and needed to be rapidly changed in order to meet the population needs. We also looked at what were the contributions which primary care services in Australia and around the world were making to COVID-19. I just have to look backwards because I don't have the screen in front of me. And you can see that our primary care services were very busy, involved early on in testing for COVID-19, involved in the care of people in their own homes, involved in helping people not to need to go to our emergency rooms and to our hospital departments. We also made a lot of contributions through primary care to clinical services and supported the work which was happening in many of our hospitals as well. And of course, we're also taking a lot of the burden off our hospital systems. One of the things we were most worried about in the early weeks of the pandemic was that our hospitals would be overwhelmed with very sick people with COVID-19, as we had all seen with great alarm occurring in countries like Italy early in the pandemic, where people were being triaged and people of a certain age or with diabetes or other conditions were being sent home, in many cases to die, because there was just not capacity in the hospital system to look after those people. So we did a lot of work, and many of you did a lot of work in boosting our intensive care capacity right across Australia during COVID-19, but also we were boosting our primary care capacity as well. We also learned that you don't have strong public health responses unless you have a strong primary care system. There's only so much that our public health personnel and infrastructure can do in a pandemic, and we needed very much a partnership between primary care services and public health services to vaccinate our population, to test our population, to provide information to our population, to manage the outbreaks which occurred in residential aged care facilities and disability care facilities across the state and the country. And in primary care, we had to change the way we deliver healthcare services. Now, this is expensive. Suddenly changing the model of care in a healthcare service to doing something different. In this case, to setting up services where people could be seen in separate situations, people with regular healthcare needs, people who may have symptoms of COVID-19, so you didn't get the two mixing and the risk of infecting vulnerable and unwell people in general practices and other primary care settings. This was an expensive model, but in Australia we converted 150 of our general practices to be respiratory clinics to do this assessment of the population, and perhaps some of you were tested and assessed in those particular clinics. And finally, our primary care services made contributions to the wider healthcare system in many different ways. And this, of course, occurred at a local level, but also at a national level. And one of the things which our GPs and our primary care nurses and others who were delivering vaccines and talking to their patients were countering was the misinformation about COVID-19. And you'll all remember that there were a lot of theories and inaccurate reports coming through, especially through social media. One of my jobs as the Deputy Chief Medical Officer was fronting up every few days to deliver a national press conference to the Canberra Press Gallery. Not an experience that I recommend to any of you if you haven't done it before. but standing up and talking to the press gallery about what was happening in the country with COVID-19. This was telecast on TV channels across the country, but also was sent out through social media. We had a member of the Department of Health team who filmed the press conferences and then posted those press conferences onto Facebook. The person who was running our media team contacted me after one of my press conferences and said, "This is amazing, Michael. You know, it was 3 hours after the press conference and your press conference has gone viral," she said. "We've had over 2 million views of your press conference from people all around the world." And I thought, wow, I must have said something really important in that press conference if it's been viewed by 2 million people all around the world in 3 hours. So I thought I'd better go and have a look and see what I had actually said. So I went and looked at the press conference, and what I discovered was that I had been filmed upside down. And the press conference had gone viral around the world with the COVID-19 doctor down under delivering important healthcare messages. So beware, you can become a meme in ways that you may not anticipate. Now, of course, our primary care services are continuing to care for people with COVID-19. We think the pandemic is over, but as many of you will have experienced over the last few months, there's still plenty of COVID-19 out there, and very sadly, there are people continuing to die from COVID-19 every day in the city and right across the country. Our primary care services continuing to deliver vaccines, continuing to do testing, and continuing to care for people with long COVID symptoms and signs as well. I recommend to you this report if you haven't seen it. It's by the OECD. It looks at what happened with COVID-19 in each of the high-income countries around the world. We, of course, at the moment have a federal inquiry underway, which was announced by the Prime Minister late last year, looking at Australia's experience during the COVID-19 pandemic, particularly focusing on Commonwealth decisions rather than state and territory decisions. But looking at this report from the OECD, they've looked at similar countries all around the world. One of the things I found most distressing reading this report was that 40% of all the deaths in all high-income countries, whether we had large numbers of people infected with COVID-19 or lower numbers, as in Australia and New Zealand, 40% of the deaths occurred in frail elderly people living in residential aged care facilities, in nursing homes, in long-term care facilities. They represent a very tiny fraction of all elderly people in any society, but 40% of the burden of COVID deaths occurred in those elderly people. And what was even more distressing was that none of the OECD countries had well prepared in their pandemic plans for dealing with outbreaks in aged care facilities. And certainly the voice of people living in those facilities was absent in planning for future pandemics. We have to do better for next time, and I hope the inquiry that's underway will do so. And that's where I'm going to stop. Thank you.
Thanks very much, Michael. So next is our panel session, in which we've pulled together leaders in health from the worlds of academic research, industry, government, and across the health services to discuss the future of healthcare and the role of health precincts. So in addition to Professor Michael Kidd, Michael, could you come up again? Sorry to bring you up again and take one of the seats. In addition to Michael, we have Associate Professor Jean-Frédéric Levesque, who's the Deputy Secretary for Clinical Innovation and Research, and the Chief Executive of the Agency for Clinical Innovation of the New South Wales Ministry of Health. We have Ian Burgess, who's the CEO of the Medical Technology Association of Australia, MTAA. It's the national association representing companies in the medical device industry. Professor Laura Poole-Warren is the co-director of the Tyree Foundation Institute of Health Engineering and leads a research group focused on the design and development of novel materials for neural electrodes. We have Dr. Shani Dyer. She's the former CEO of ARCS Australia. She's an experienced director and senior executive with roles across industry, government and universities, vast experience in technology commercialization, regulatory affairs, and clinical research. And Professor Nick Fisk is the Deputy Vice-Chancellor of Research and Enterprise at UNSW. His role is to optimise research, innovation and commercialisation for the university. Nick's a very accomplished academic himself, having a background as a clinical scientist in fetal medicine, has published over 400 papers. Welcome to our panel, please. So audience, please note that there's a QR code up there, which we'll come to some questions. I have some pre-prepared questions for the panel to begin with, but do please put your questions into Slido and we'll get to a couple of those at the end. I'm going to begin, first of all, with Nick, right at the end there. One of the questions that's come up is consumer empowerment, increased health literacy, and a focus on wellness and prevention have been put forward as key changes in attitude we need to adopt. Is our health system too entrenched in the last century's attitude of treating illness?
Thanks, Steve. So easy one to kick off. Look, full disclosure, first of all, the entire panel was promised that we would only be asked Tucker Carlson-like questions as put to Putin last week. So too entrenched? No, I don't think so. A little entrenched, yes. Now, for the 24-year-olds in the audience, last century medicine was imprecision medicine. It was sole trader, hero-based. Experiential medicine. It was paper-based, disease-focused, hospital-centric, paternalistic. Now we've come a long way since that time. Digitization, huge technologies, lots of evidence-based treatments, drugs, procedures, etc. We've had a shift to primary and community-based care, at least in part, and respect for patient autonomy. But if you want to see how joined up the whole system is, just go and look at your My Health record. That should answer everything. So, look, we've had a lot of changes in the last 5 to 10 years in terms of empowerment, health literacy, prevention, wellness, etc. And community input, patient advocacy, etc. has been a key part of that. But we've got a long way to go. Now, human beings tend to overestimate short-term change, and they underestimate long-term change. And Michael, I was reminded of an editorial I wrote in The Lancet in 1995 about telehealth, then called telemedicine, predicting that it would be widespread by the early 2000s. Well, just took your pandemic and another 20 years for that to kick in. But look, the crystal ball that Michael showed, today's session is about what's going to happen in the next 10 to 20 years. That's up to 2044. So I think we're on the brink of an amazing disruption, particularly in AI, even quantum computing-based superintelligent, in genomic treatments, anything from base editing through to nanotech-delivered drug delivery, for VR robotics, through things like 3D organoid transplants, just to mention a few. Now, they're pretty dramatic things at the spectacular end of medicine. But in terms of things like prevention and consumer empowerment, technology will be a big deal. So precision AI-based diagnostics will have a huge impact, leading to early intervention. So just this week, Nature Aging's published a paper of 4 of 1,500 proteins in your blood will predict 10 years in advance with a high degree of accuracy whether you're going to get Alzheimer's. Consumers will have access to transparent, authoritative information, really will empower them. Your healthcare practitioner or team will be informed by AI-supported clinical decision-making tools based on hundreds of thousands, maybe billions of hours of training. But above all, things like your watch and your phone, apps, wearables, etc., electronic tattoos, they're going to make a big difference to personalised wellness. So just looking at mine from this morning, I get 19 air miles every time I exercise. That's terrific. I won't mention the one I don't do so well at, which is how long you put your phone down in the middle of the night. Look, there are risks to all this stuff as we put it all together in pursuit of shared decision-making. We could lose the human touch in provision of healthcare. But Google AI in January published this thing compared to really experienced primary-based physicians. Their chatbot obviously got the diagnoses right more often, but was considered more empathetic than the primary care physicians by the patients. Watch this space. Michael's talked about the equity problem, when we need to balance quality versus cost and provision, etc., the spread. We're at real risk with some of this of overdiagnosis, over-service provision. Just think of the semaglutides, the incretins at the moment. It's estimated that 10% of Americans are on these weight loss drugs. Most of them don't need it. So much so that when there's a new drug trial, the price of things, the share price of things like Walmart goes down because Americans are eating less. Interesting. And the new triple therapies, we not only have the GLP-1 agonists, they've got GIP agonists and a glucagon agonist, will make you lose 22% of your weight in just 12 months. That actually quite scares me. I worked out what mine would come down to. Over-pathologization, that's part of that. Mental health scenario. We've got some great things on the horizon in mental health, but PTSD, we probably over-pathologize that, and maybe ADHD as well. I'm worried about the industrial capture of the large language models AI stuff. It's not going to be driven so much centrally, it's by private profit-based enterprises. And then, Michael, you mentioned fake news. We've got fake health, snake oil stuff through to willful misinformation, etc. So look, prevention's great. Democratization of healthcare is great, but remember, it's not lifespan, it's health span we're interested in, and that for Australians, for half the years you will live over the age of 65, you'll have disability, frailty, or dementia. So I've just given you a snapshot of some of the predictions of the drivers, the long-run drivers over the next 20 years. Prediction's always a bit tricky. It was Niels Bohr, the Danish Nobel Prize winner, who said predictions especially difficult about the future. And I look forward to hearing the other experts drill down to the component domains that are going to hypercharge our Randwick Health Innovation Precinct.
Thanks, Nick. Any thoughts or comments on what Nick said there, or any thoughts about consumer empowerment? Shani, look like you've got something.
Yeah, look, I think, Nick, that really sums up a lot of the issues that we need to be addressing. I think the point that you raised around wellness, and I think, you know, from our hospital systems perspective, we need to differentiate people who are effectively well. They don't have a chronic disease that can't otherwise be controlled by apps and wellness and steps and things that can keep them in a healthier state than a lot of people are at the moment. But differentiating then between people who are well and then people who have got a need to go to a hospital because they have either a genetic-based or environmental-based illness will help to alleviate the pressure on the hospital system in the future. So the future is about maintaining the wellness of people so that it's only the people who are actually sick that need to go to hospital into the future. And so we've got to utilise those technologies, those apps and your phone telling you to do certain things to keep you fit, because it needs to be, you know, good for you. It needs to be personalised to you. You don't need to do all the weight loss, right? But somebody else might need to do that, or need the steps, or you know, those other things. So I think that's a pretty important point, that we need to differentiate people who are well.
Yeah. Thanks, Shani. That's a great segue to the next question, actually. So, Laura, the current government have set innovation in medical science as a priority for boosting advanced manufacturing and strengthening our sovereign capability. In terms of this health and technology development, do you think Australia has all the elements of the health technology innovation ecosystem it needs to succeed in that ambition? And if not, what are the areas where we need more focused investment to enhance our health tech innovation capacity?
It's an easy one. I think to achieve the future vision of healthcare that Nick has mentioned, innovation is absolutely essential. We need to innovate, and we need to think about first, what are the components of innovation before we can answer that question. So, I mean, the typical roles or components that you think of are, well, you need government, you need business and industry, you also need, in the medical innovation space, you need hospitals and the whole clinical infrastructure. Plus, you need the knowledge generation and education. So you've kind of got this quadrant, this wonderful quadrant that you can imagine all of the activities going on. And I think Australia does, yes, have amazing pinnacles of excellence in all of these areas. But where we really do need to work hard is in the connectivity between these. The policies, the systems, the infrastructure in particular, to look at how all of these work together. Because at the moment, what we find is that we have a lot of duplication occurring across the systems. We have competition where there shouldn't be competition and there should be collaboration. And I think that one of the things that the Health Innovation Precincts can really help us do is to bring together a lot of these components to work towards very efficient solutions in this space. And I can give you an example as co-director of the Tyree Institute of Health Engineering. We've actually implemented up in the Southeastern Area Health Service some digital capabilities to actually monitor patients at home. Work done, and it could not be successful without the support of the hospital system, without the support of the clinicians, so fantastic clinicians up there, in particular Sianui, who's a cardiologist, with the technical excellence, so Nigel Lovell and his team, he's a co-director of Tyree Institute of Health Engineering. All of those are absolutely essential to actually implement something like this. There's probably a lot of other factors that I could talk about, but I think you need to actually bring these people together, co-locate people, make sure that those connections are happening and give them the sort of the underlying policy and systems and infrastructure that's going to support them. I'm relying on Michael to solve all of the policy issues. And I think Ian, with sort of industry inputs and industry connections, is fantastic. But I think in terms of the health systems and the clinical areas and the knowledge generation and education, we've got a prime opportunity to bring those together up in the precinct and to really make things sing. And not just our precinct, to also get Randwick working with Liverpool and, you know, working with the regional areas. So I think it's a great opportunity. I think that there are a lot of factors that still have to be considered and sorted out in the system, but I think that we're entering in a really exciting time. I think Michelle said that. I think this is such an exciting time to be in this field. So I'll leave it there. I think there's probably other people that might want to comment on the innovation system, including Shani.
Thanks, Laura, appreciate it. Any thoughts or comments that were raised for other people?
Am I allowed to? Look, yeah, oh, of course. Okay, so look, you know, I agree. I think the thing, and I think who was it? It was Attila who brought up the concept around the precincts being about people, and it's about, you know, connections with people and the right people. So, you know, it's that thing about communication as well between those groups and making it work. So a building doesn't do it, but it's about the interconnection of the people in the area, and yeah, that's just a key point, I think.
Great point, Shani. I have a question for you, Shani. So obviously the important part of health technology development is the economic growth it offers to Australia, and Australia has got some great notable global health technology companies such as CSL, Cochlear, ResMed. How can we support the emerging local startups many of which we're seeing co-located here at UNSW, to grow into those small to medium enterprises and create more of them for Australia?
No, thanks, Stephen. Yeah, good question. So I think everybody, you know, hears about CSL, about Cochlear, ResMed. They're always brought up as you know, the shining lights, but I might say that probably their genesis was like a unicorn, because the environment that they were in and the reasons they started, you know, have not been replicated as well. And we have a number of really good small to medium-sized companies out there already, not the size of CSL, ResMed and Cochlear, but also really, you know, punching above their weights. But it's the environment and again, the people in the workforce that are here in these environments, such as precincts, that can enable SMEs and other biotech companies to bring forward really fantastic innovations. And we need to really support that. And there's a number of things that we need to do. And one of those is about the large multinational companies that are based here in Australia. How many people here in the audience are from a large multinational pharmaceutical medtech company? Two, okay. Cool. 3, okay, out of the audience. It's about 1%. Of the audience, how many of you have spoken to anybody from a large pharma medtech company in the last, this year? Okay, that's better. That's better. That's probably maybe 10%, okay. What those companies bring to Australia is access to a pipeline of amazing drugs, devices, etc., that really enable and build our clinical trial environment, which is incredibly important for the development of our SMEs. So engaging with larger companies, international companies, is crucial, and they're not the scary people that you think they might be. Of those 10% of people who have reached out, good on you. There's not that many people represented here, which is a problem. Why aren't we having these kind of discussions with these companies present? That disconnect where we're all alike, okay? We've got to bring in the people who think a little bit and speak a little bit differently to the way we do, to enable those conversations, to enable innovation. And I can't but talk about the enablement of companies in innovation without talking about policy. And we've got some of our government colleagues present here, but it's probably not just state-based policy, but federal policy that is incredibly important to growing our companies and providing opportunities for them to grow. And part of that, which also goes to the larger companies' interest to be in Australia and be research active, are things such as our HTA systems, our health technology assessments, our reimbursement of life-saving drugs that these companies can bring into Australia. And the systems and processes in which they are assessed are very much last century, or I think, or even maybe the century before. And they speak to the classical chemically based pharmaceutical entity, or the standard medical device, and they don't, to me, talk to our digital technologies, our combo software platforms and devices, and images that use big data to make analysis in pathology. Those things are lost, and we don't know what path to take them to. So, I think 10 years ago we should have been reassessing the way we assess what technologies are going to be successful in Australia. Because I can tell you, if a company can't get their product reimbursed in Australia, they're not going to bring their clinical trials here. It's just, it needs to be balanced. All the activities that we do, if you don't get reimbursement, there's not going to be clinical trials. If you don't have clinical trials, you're not going to have the big companies. And there's going to be an absolute increased chasm in Australia. The other things that we can do is to build platforms and digital, or access to digital information that will be inducive for companies to come here, because they can access patients. And I think that's going to be really important as well. So access to big data, making an environment conducive for big companies to come to Australia, will enable those smaller companies to grow. So you need that environment. You need precincts to have a focus for companies to come to. In my role in Investment New South Wales, I'd have companies going, well, where do I go? What do I do? Somebody said something about an R&D tax incentive. What's that? So communication, incredibly important. Connection with companies, getting them to be involved with smaller companies if we have the right environment and the right policy setting. And of course, I can't not say things about building the workforce. That's incredibly important as well. Just one thing, because I know I'm short on time, but the fantastic precincts that are being built here at Randwick and we've got a number of other precincts around New South Wales and around Australia. These are not competitive entities. These will be most successful when they can work together, they can collaborate, and they can identify each other's strengths and not compete with each other. I'll just stop there. Thank you.
Anyone feel inclined to take up the Shani's issue about policy settings or about our relationships with industry?
Just a quick comment. They're great comments, Shani.
Thank you.
And particularly around the policy settings, there's numerous valleys of death along the commercialisation journey. And we currently have, particularly at a federal government level, policy settings that exacerbate those valleys of death. And when we're not getting those policy settings aligned, and we don't have a whole of government approach, so we have a National Reconstruction Fund, of which there's $1.5 billion for medical science, for medical devices. And that's great, but at the same time we have policies within the Department of Health and other parts of government that are actually doing worse than not encouraging, but are counter to those initiatives and those policies that are being developed through Department of Industry, for example. So we need to get those policy settings right, because there's enough challenges as it is to get through the R&D, to get through the valleys of death of commercialisation. And it's about investment in Australia, and how do we encourage investment in Australia, whether it be a large multinational or a small Australian company. We have a thriving R&D and start-up sector in Australia. We have multinationals that want to invest more in Australia. We don't have enough capital in Australia, which is another problem. And there's various policy parameters and potentially taxation incentives that can address those issues too. So, fully agree, Shani.
Yep. No, absolutely. And it's surprising. I mean, we did speak, but.
Thanks, Ian. Great points. I've got a question for you. This one's about digital health, and I think which impinges both on the technology aspects, but also the pace of implementation. So it's an area where technology advancement is far outstripping our ability to embed it within the health services. What do you see is required in Australia to see more digital health solutions, particularly kind of the virtual care, adopted and implemented?
Yeah, and we are at an exciting stage of the health system, as I think pretty well all of the speakers have said so far. And a large part of that is also around technological innovation and digital health. And to maximise those opportunities, there's a lot of barriers that need to be addressed. So to maximise the data access, the data analytics, we need to ensure that there's essentially a national governance framework in place that enables access and does so efficiently and effectively. Need to address privacy concerns, and that's partly around, together with cybersecurity, ensuring the robustness of the system, but trust in the system. And when we're talking about empowering patients, ensuring that patients understand the system and trust digital health, trust that their data is going to be used properly. Then we've got, I've mentioned cybersecurity, we've got particularly around digital medtech, I would describe it, ensuring that we've got those policy parameters right. It's pretty hard to get away from those. So there's two parts to that. One is being able to bring digital technology into the market, so that's our regulatory processes. TGA is a world-renowned regulator, but a lot of its timelines are slower than international comparators. And then around reimbursement, funding and procurement models. That is probably the biggest challenge for greater uptake of digital health in Australia. We really don't have a reimbursement pathway for digital health across the health system, whether it be fit for purpose or anything really for that matter. There are some funding models, and there are pilot programs, and there are some niche reimbursement models. But to fully enable digital health, we need to have a reimbursement model that actually recognises the differences for digital health. Evidence requirements, you just can't collect the same evidence for a digital health as you can, for example, for a pharmaceutical or a medical device that's implanted. And the rapid turnover and the rapid iteration in that innovation for digital health is even more so than other technologies. And to get that take-up, our procurement system, and this is a longer conversation, needs to fundamentally flip from focusing on short-term cost minimisation to a proper assessment of value, and particularly for digital health, it's assessing the value across the life of the patient and also across the value of the silos within the health system, and ensuring that value that is captured in one part of the health system is actually recognised across to the payer. And so that's not a simple solution to address that. But there's some great innovations in New South Wales with value-based healthcare, and we're very keen to be engaging on that.
Thanks, Ian. Great comments. Any pickups on any of Ian's comments at all? Anyone like to?
Just agree with him.
Yeah. Well, that's very important. All right. Okay. Well, let's move on to the subject of health innovation precincts in general. Such as ours here in Randwick. We see them as key strategic elements to foster collaboration and clustering of health services, public research and industry to derive better health outcomes and economic growth. Jean-Frédéric, what do you think are the key elements in health precincts to ensure the success of a precinct-based strategy?
Thank you, Stephen. And I think I'm going to touch on some of the points that have already been made already, of course, and maybe we'll use my response to contribute to some of the discussions or debates. But before I do so, I always go back to the research and the evidence. So I did a search on the effectiveness of precincts, as you may expect. And then what I wanted to highlight was potentially what was the role of public sector organizations in making them work. They talk about you need to understand the market drivers, and then, of course, align the regulatory environment so that you can have a well-functioning innovation. They talk about competitive advantage of the precincts so that they don't all try to do the same thing, finding a cure for diabetes, for example, but instead really truly find something that will make them different. Collaboration internally so that the real value of a precinct is generated through the informal social collisions through to commercial frameworks for joint ventures. And I have to say that I've not seen many precincts really succeeding at that specific one. The infrastructure, the amenities, but then also the enterprise culture. Absolutely important to make precincts work. And then when precincts have public sector organizations in them, that can be a challenge. And finally, leadership, because it's not easy to manage those difficult ecosystem, especially when you don't control all of the stakeholders and when things change very fast, especially when they change very fast compared to the healthcare system. So if I reflect on those drivers, I think public sector organizations need to be really involved in those place-based approaches because first you need to position those places in a geopolitical sense. If not, then it just becomes a localized kind of effort. But the reality of precincts is that they're useful if their local characteristics have an advantage in the global space. Networking the precincts together, especially in a place like Sydney, where we do have a lot of precincts in comparison to other places. And we're not selling it as a Massachusetts, we're not selling it as a Texas or as a Bay Area. We're at the moment still developing them in not isolation, in collaboration, but not necessarily coordination. So that they really start to demonstrate what it is to invest in New South Wales in terms of biotech, medtech, etc. And we can help from a governmental perspective to create that networking by bringing people together. Generating the critical mass, ensuring that we invest in the right place, and investing in the mechanic of the precincts much more than in the building of the precincts. And that's a real challenge. And we've offered a lot of support to the various precincts to work on that specific aspect. The infrastructure, of course, it's the physical infrastructure around the precincts, but data has been mentioned, and of course, governments and ministries like the one I work in can help to mobilize that data in a safe environment so that it can promote innovation. But I would like to argue that one of the biggest one is the clinical. There's lots of precincts that are based on a commercial and involvement of some clinicians into them kind of philosophy. But here in New South Wales, we've got a fully integrated system. We can mobilize hundreds of hospitals through the mechanic that we have and the governance that we have. And that's an asset that we need to mobilize for precincts because a lot of companies are looking for sufficient numbers for clinical trials, especially in precision medicine. That's going to be a challenge. If you only have one center of excellence in a state mobilized by a precinct, and we know that this happened in other places, they're not competitive. Whilst if we mobilize dozens of clinical centers, we're going to be able to reach those. And again, I think we can really help and be a partner in those successes. And finally, in terms of leadership, of course, it requires regulatory alignment and sufficient funding and sustainability in funding so that we become competitive. But you cannot do that outside of the democratic instruments that we have, and that's called an elected government with specific priorities. And we need to work together so that those entities are really seen as being an extension and a leverage of the delivery of care for the population of New South Wales. And that's where I think that our multiple precincts, which at time, again, can be a challenge, can actually be a strength, because we can then really have an excellent coverage across the system and demonstrate that it can really be part of usual delivery of care. I'll just finish with potentially some barriers. We've already mentioned the barriers to investment and commercialization, the lack of entrepreneurial culture very often present in government. The poor access to capital is often mentioned, and you've mentioned that, Ian, of course, and we know that in Australia it's a challenge. And the poor access to skills. And that's one where we can have an advantage because we do have an excellent pipeline of skill in biotech, medtech, etc. But it needs to be accelerated. We're not ready to bring a lot of things at the manufacturing stage with our current pipelines. I would like to finish with a paradox. And the paradox is we need to use precincts and all of the innovation that and translation that they will drive to make both the populations as well as governments and clinicians in systems aware of the fact that we may face very soon a situation where there will be a very, very costly, extremely pointy-ended intervention that we will need to provide to patients in comparison to a lifelong of cumulative costs. One treatment provided once to a patient can completely change their trajectory for the rest of their lives. How do we make that shift in funding? It's going to be a real challenge. And how do we demonstrate the value to the population and government? It's going to be a real challenge. And again, I think it's only through partnership between public sector entities and industry that we can do that, and precincts can be a fantastic vehicle for that.
Thanks. Very appreciate it. We're going to come to cost in a sec. I just wondered if the panel, Nick, I noticed you were writing a few notes there. I don't know whether you want to make any comment. No, that was just note-taking.
So, Jean-Frédéric, the precincts often start sort of bottom-up, bit scattergun approach. Everyone wants a precinct. And the interaction of sort of government and high-level support is the thing that makes them flourish. But do you really see it as a sort of 100 flowers Darwinian survival, or some precincts are far too important to fail?
I think the investments have been too important to adopt a 1,000 flowers bloom kind of perspective. We need to combine the bottom-up approach, because innovation works this way, but with a very clear visibility about what's happening, and then creating the alignment so that we progress to scale the things that are the most promising. Other cities do not have such a concentration of precincts, and therefore it's both our challenge as well as our opportunity. It's our challenge because maintaining the activity in them is going to be demanding because of their numbers, but it's an opportunity because they can all really take on the role to bring New South Wales to the world stage if they work in complementarity, And again, that's something that from a New South Wales health perspective, we're committed to try to facilitate, and at times provide the resourcing or the authorizing environment that may create that. And how do you combine that with, innovation emerging and then scaling it at the right place at the right time may require a bit of political discussions as well.
Yeah, I think the concept of having the precincts, am I allowed to speak? Yeah. Is
very brief.
Very briefly, okay. Is good. I mean, New South Wales has a number of precincts, whereas others might, Victoria might have one main, or probably two by the time we got Parkville and then Monash. But we're so much bigger physically and from a geographic perspective that we do need to have more of those precincts. And I think your point around these are precincts not just in New South Wales, but they face to the world, and that's our customers are going to be the world.
Sure, but I mentioned the numbers in light of comparing it with Toronto, for example, which has one single big precinct and really trying to concentrate everything around that area. Montreal's got two. They're significant cities. We need to find together a strategy to harness that diversity. And it could be that our precincts are really a way into real healthcare. And I think that with precision medicine, that's what pharma companies are going to be looking for, that access to patients. Access to patients that we diagnose, sequence, and then we match with a clinical trial. I think that can be our advantage.
Yeah, absolutely.
Terrific. Thanks for that discussion. We are running a little over time. If everybody does need to leave, do feel free to go. But I'd like to continue this discussion just for a little longer because I think it's really interesting and important. The cost issue. Michael, in your talk, you mentioned equity of access as being the #1 question for the Centre for Future Health Systems. Healthcare affordability for governments and individuals with rising out-of-pocket expenses, private health insurance premiums, an issue that's impacting that equity of access. What approaches can we take to combat the cost issues?
So this is something where you've probably all got a view about the cost of healthcare services and where do you get access to healthcare services, and are you getting value for money when you do pay out of your own pocket for healthcare services as well. And it's not new. There have been pressures on our health systems and pressures on our health dollars for a very long time. So this is not new. What happens though is there are waves of public awareness, public agitation, which gets the attention of governments and policymakers. We're seeing that at the moment with our federal government being very focused on bulk billing rates in different parts of the country and the challenges that some people are having in getting access to timely appointments in general practice with their GP or the nurse who's working in their practice. We're also seeing, of course, in different parts of the country, real pressures on hospital services, especially on emergency services, pressures in being able to get an ambulance in a timely manner and being able to be seen in an emergency room in a timely way as well. And these things rise, and then decisions are made about investments. Now, sometimes the investments are very sound and they're based on good evidence, and sometimes they're based on knee-jerk responses to what appears to be a real pressure. And we in last year's federal budget, we saw $6 billion allocated to strengthening primary care services to try and make sure that general practice services were available to the population. When you break that down, half that $6 billion was on new medicines and vaccines, which are very important, but they're not doing anything to strengthen what's happening in our primary care services. But some of the others were around new innovations to try and improve the high value care being provided in primary care. The patient registration initiative, where you're now all able to register with the general practice of your choice, and there'll be payments which flow with that to improve particularly the management of chronic disease. That's terrific. The investments in having more team-based care in primary care in the budget, so more funding for general practices to employ more nurses and allied health professionals and others to work in their practices, again, to deliver better care to the population they look after. And then investments in new technology, and we've heard about new technology, but particularly in the telehealth side of things. We've seen, Nick, at last, a real revolution in virtual care being made available in Australia, including through our public health systems, which again is adding to the opportunities of people to get access to healthcare where they may not have. This is particularly important for those living in rural areas where remote access through telehealth is providing people who would otherwise have to travel very long distances to get access to services. But it comes down to the crunch of what are we willing to pay as a community and as individuals? Is it worth your while investing in private health insurance? For many of us, yes, because the penalties for not doing so, taxation penalties, are very, very significant. Is it worth your while paying out of your pocket for some of the health services which you receive, and people are making decisions as to whether to get access to those services? It, though, is having a real pressure on many families, of course, which are suffering from the cost of living pressures that we're seeing. So it's a very complex question. There's no simple solutions. We hope that our governments will make sensible decisions which improve equity for everybody, improve the healthcare services that we have. It's up to us, of course, all to put pressure on our governments to make sure that they're investing where they should.
Thanks, Michael. Appreciate it. Any last comments on the cost issues in particular? I think we're going to have to close it very shortly. So, any last thoughts about it?
There is a steady progression of people heading off to Valentine's Day dinner.
Well, in the interest of that, I think we'd probably better close the session. Please, everyone, please.
Can I just say one thing?
Oh, yes, absolutely. Jump over it.
We've heard time and time again that there's low value care in most modern healthcare systems, and I truly believe that that's the case. But I just want to say that increasingly we realize that, yes, of course, there's procedures that we shouldn't do because they're not effective and they don't benefit people. But the volume is not really big. Then there's care that we should always provide to people because we know it's extremely effective. And again, it's not really where there's a lot of low value. There's a lot of low value in the lack of capacity to bring patients directly to the service that they need. And there's going to be opportunities coming out of the innovation that will, in many areas, and metabolomics is also going to revolutionize the way we can diagnose illnesses. But at the moment, there's absolutely no structure that would enable us to coordinate that more specialized access for our patients. So patients go and visit many different GPs or specialists, et cetera, and that's where there's a lot of waste. And it's not because the patient doesn't do the right thing. They're trying to access a diagnostic, trying to access the right treatment, but very often they end up in in clinical areas where they cannot benefit from the service that will be provided. It's as simple as that. It's not bad care, it's just not the right fit between the patient and the provider. And I think that we, again, need to understand as part of the innovation that we think about, always trying to work with our innovators so that it lands straight away in a model of care that can work. And I don't think we've nailed it.
Thanks, Geoffrey. Okay, we'll leave it there. We could talk about this for hours, but panelists, please feel free to return to your seats. And I'm just going to ask Michael Still if he can return to the stage to make some concluding remarks before we close the meeting.
Well, thank you, particularly panel members. Gosh, we've heard a lot this afternoon. What did we learn? What was the essential message that we heard this afternoon? For me, there was a constant questioning of how value is generated. Toby talked about the importance of integration, of research and clinical practice, attraction of workforce. These are terribly important issues. Attila talked about the importance of a precinct as an opportunity to reimagine. And we're all here, and particularly the panel members, reimagining what healthcare in an integrated form might look like. Michelle shocked me terribly, saying that more children die of cancer than any other disease. It's extraordinary. But what does it all mean for a precinct? What does it all mean for this group of people? I think what we heard was that innovation and progress needs connected people, an enterprising culture of many disciplines in co-location, thinking in a range of ways and approaches, supported by government on behalf of the populace. In other words, a precinct. If we can bring precinct thinking as a terms of thinking, as a way of thinking together, we will no doubt make great gains, great progress, all that has been described here this afternoon. So let's take it away and see what little bit we can add to that progress. And thank you for being here very much.
Thank you for that. Apologies again for running over time. That concludes the formalities of this Mind the Gap seminar on the future of healthcare. I hope you found it as interesting and engaging as I did. As Michael mentioned, it is St. Valentine's Day. I'm sure many of you will be rushing off to dinner with your romantic partners. If you do have time, we'd love you to stay for a nibble and a drink in the foyer outside. You can continue the conversation or perhaps make a new connection. Thank you for coming, everyone. Thank you for our wonderful panelists, distinguished guests. See you outside, or if you're rushing off, happy St. Valentine's Day and safe travels, everyone.